Hi, everyone. I'm Liz Thompson, the CEO for the National Eating Disorders Association. And it's my privilege to start off our NEDACon this year focused on the research that we're funding and fueling here at the National Eating Disorders Association. Today is the first in our series, and it focuses on special and diverse populations. We're really excited to have two amazing experts here with us today, Dr. Erikka Dzirasa and Dr. Rachel Wood. Each of them will be talking about the projects and that they are carrying out and the research that they're doing. And then we'll have a series of conversations that highlight what needs to be done, what is being done, and what needs to be done for special and diverse populations, specifically in eating disorders. Dr. Dzirasa is a double board certified child, adolescent, and adult psychiatrist who has been committed to serving individuals and families impacted by eating disorders for over 10 years. And we're very excited she's joined us today, and we'll look forward to hearing more about her background. Dr. Rachel Goode is an assistant professor at the School of Social Work and in the Center for Eating Disorder Excellence at the University of North Carolina at Chapel Hill. Her research interests include developing, implementing, and evaluating interventions that address health disparities in obesity and disordered eating outcomes. Dr. Goode, we're delighted you're with us as well. I would like to turn it back to both of you to just share a little bit more about your backgrounds and how you came to this work, what you're excited about. Dr. Dzirasa, would you start, please?
Absolutely. Well, thank you so much, Liz, for having us today. I'm just so honored to be here to talk about this, to talk about eating disorders amongst diverse populations. It's something that I'm really passionate about. So I'm just excited that we are having a conversation today. So a little bit more about myself. I was trained at Duke. I went to medical school and did my residency and fellowship at Duke. And it was during my child and adolescent psychiatry fellowship that I realized, okay, I probably, as a child psychiatrist, should learn a thing or two about eating disorders. So I actually requested to do some additional time working with the Duke Eating Disorder Center just to learn more about it. It was something, it was a rotation. It wasn't even something that was required. And I was blown away because I learned so much about eating disorders, and that it's not a stereotype as I thought it was. And, learned a lot more about how so many different individuals can suffer from eating disorders, and that there's so many different types of eating disorders. So it really helped to enrich my career moving forward. I ultimately became a medical director of an eating disorder hospital here in Durham, North Carolina for a while before I stepped out into private practice, where I'm the co-owner of Catalyst Therapeutic Services here in Durham. And I also, because I'm passionate about the work, I'm passionate about diversity. I've served on as the immediate past president of the North Carolina Child and Adolescent Psychiatry Association. And I also serve on a race, ethnicity, and equity association with North Carolina Psychiatric Association. And I'm currently serving as the chair board for Project Heal. And I'm really excited about that. That's something that I've been doing over the past year. And we're just really passionate and excited about getting individuals with eating disorders the treatment that they deserve and need. So I will pass the baton back to you.
Dr. Goode, please tell us a little bit more about you.
Yeah, it was so great to hear your background, Erikka, and just to be able to nod in agreement just about, our starts are so important, and just thinking about the things that get us going. And so for me, I think I kind of accidentally came into this field. I practiced as a clinical social worker in college counseling. And so I think to start, I had my own journey with food that we all do, right? We all have our own stories. And so I had my questions as I was seeing my clients. I'd see, when we think of traditional college age eating disorders at the time, I saw several clients with those concerns. But then I also had the chance to practice in a community-based setting. And so most of my clients were low income, African American, and so I wasn't seeing, we didn't have the labels for disorder eating that I was used to in the clinical college counseling center, but I saw some other factors that I noticed were also, I felt like this might also be disordered eating, but they were attached to things such as food insecurity and trauma, and recognizing, wow, we don't know as much as we need to about some of these other concerns. And I realized as I was practicing that, when I would talk about disorder eating, I would get I had to do a lot of education because it was just, there really wasn't the language for it, and so it was really challenging to realize, well, where are the interventions? And I would look and I wouldn't see as much out there that I thought might be relevant to this population. And so all of that kind of fueled my desire to go back to school and to really begin to kind of do more research so I could develop intervention research for, disordered eating that would fit, that would kind of fit into the mold. Because we know, the thin ideal isn't always the reason why people develop disordered eating. And so we need programs that support that and to really help encourage and make it in a language that people can understand. So now that I've transitioned into my career as a researcher, I get such great joy out of people being like, I got it, Dr. Goode, I get it. I understand what you're saying. And I think it's important that we're able to translate, what we think maybe is the problem so that we can find really adequate solutions. So I'm really grateful to be here with you all today.
I love that. Yes.
That is so powerful. And the passion that both of you have for your work just clearly comes through. Thank you so much for your leadership and the knowledge and the energy that you're putting to make in change. Thank you so much. Dr. Goode, you really positioned us beautifully, I think, for the next part of our conversation. Thank you for doing that. I'd like to go back, Erikka, and have you characterize the work that Project HEAL is doing under the grant that we funded on access to care, because that's really when a big part of why we're missing people. So would you please characterize where that work is and how it started?
Absolutely. So Project HEAL is really excited to partner with Dr. Sherry Levinson of the EAT Lab, the Eating and Anxiety Treatment Lab at the University of Louisville, to conduct the first ever quantitative study about the barriers that people face when they are trying to seek treatment for their eating disorders. And when we think about the barriers, what are those systemic barriers? What are the healthcare barriers? And what are the financial barriers, right, that prevent people from truly accessing care? And what we're doing, we're looking at a survey of individuals to try to see, okay, what are the trends? What are the trends that we're noticing? What are the patterns that we're noticing? And we really want to know, how does that shift depending on the population, right? So what does that look like amongst boys and men with eating disorders? What does that look like in the LGBTQI community? How does that impact the BIPOC community? Those with different body types, those with different types of eating disorders that often are neglected in the research. So we want to really understand, what are those barriers? What are the trends that exist, and hoping that ultimately it will reform really how we see eating disorder treatment. I think Dr. Goode gave us a little bit of that. I'm excited. I'm like, I have questions for Dr. Goode about these interventions, but how is that going to inform our treatment moving forward, right? We have to make sure we understand that this is not just, a one fit, kind of solution for everyone, that eating disorders are so diverse and they're so complex and they impact so many different individuals who, we also have to think about the intersectionality of those identities, right? And how we are addressing the barriers with interventions. And also I'm hoping, and we are hoping at Project HEAL, it might even provide some way for us to provide lobbying, and to be able to say, okay, how can we influence change from a policy standpoint in making sure that individuals really get the treatment that they deserve and need. So that's a little bit about what we're doing. We're still in the process of collecting survey information. So we don't have data just yet. We have some ideas about what we we expect to see in terms of those populations I just described, and some of the disparities that come up and addressing those barriers. But we're so excited because we think that this is going to be so rich with information. It's going to really help us navigate. Okay, what are the next steps? How do we really do this? So that's just a little bit about what we're doing.
That is so exciting. And at NEDA, one of the reasons we were excited about this project is the depth and richness of it. But we also firmly believe that it will help us set an agenda for policy for the entire field. So we are anxiously awaiting top line data and really looking forward to seeing how this can shape the field. One of the things that you touched on was the importance of creating interventions that can change health outcomes for people. And at NEDA, we were delighted to fund Dr. Goode's research, which is really intervention based, and she highlighted that in her comments. The project that we funded Dr. Goode for was called Preventing Binge Eating Disorder Among Black Women in Primary Care. And tell us how you created that concept and then really where the work has gone.
Sure, sure. You think about one of the barriers is, the access is where do you go, right? To get if you had a concern about your eating, who would you go see? Where would you go get this help from? And so what I saw in the literature is that African Americans tend to go to their primary care physician, right? To get what they need first. That's their first stop. And so it would make sense, maybe one way to increase accessibility is to have that be a place where individuals are able to get treatment for disorder eating at the same time. And so I was able to partner with the Department of Family Medicine at UNC, and they have a social work clinic where individuals, they really have a integrated care setting. And so we were able to recruit women and it's funny because we recruited women because people don't know that much about eating disorders. We recruited individuals who expressed interest in weight management treatment, as well as individuals who were able to recognize that some of their eating might be disordered. And so we were looking specifically at those who kind of identified as having binge and loss of control eating. So these individuals did not need to be diagnosed with binge eating disorder, but they just needed to be at risk, right? So we looked at individuals who had, at least weekly, bi-weekly binge eating episodes. And so we involved them in a combination. We used appetite awareness training, which is a intervention developed by Linda Craighead. She's out of Emory University. And so this intervention was designed primarily for individuals who are managing binge eating disorder or bulimia nervosa, to really begin to help them realign with their biological signals of hunger and satiety. And so when I thought about what I knew about African American culture, food is so central to us. It has been a tool of healing. It has been, what we use, especially our women use to kind of take care of themselves when they have, are dealing with some of the great stressors of the world. Food is kind of like, I'm going to relax. I'm going to, at night, I've done everything I need to do for everybody else. I'm going to take care of myself and eat this. And while, we understand the need to soothe, we also recognize that a lot of this is hiding things that maybe have gone untreated, and disorder eating that, with support could possibly be improved. And so we invited women who identified with those characteristics to come and participate. And so we combined it, though recognizing that a lot of them were interested in weight loss still, we combined it with a lifestyle intervention. So individuals got nutrition counseling. So we weren't talking about weight or anything like that, but we recognized that desire was in the culture, and that was what they recognized. And so as a social worker, we really find it important to start where the client is at, right? And so even though I might want them to be, accepting of where they're at and to kind of help them to recognize the health at, whatever size they're at, their ability to obtain health, I also recognize that they had desires for weight loss that I couldn't ignore, and to, just kind of look past and act like it wasn't there, because I was coming certain where the culture was at. And so we found ourselves able to have good conversations and really begin to weed through, right? And so they had started with 8 weeks of appetite awareness training. So in that program, the individuals were able to learn and got self-monitoring to relearn their biological signals of hunger and satiety. So it's one thing to say, eat when you're hungry, stop when you're full. It's another thing to get feedback every week on how you're doing with that, right? And we're able to see change occur because how change is, it's incremental. You take steps back, you go forward. It's all over the place. But we were able to kind of help people get a good foundation for just recognizing, oh my goodness. And that's kind of what the first weeks were like, wow, I didn't even realize, just kind of some aha moments in recognizing their relationship with food and some of the things that were impacting their eating behaviors. And then we spent the last 8 weeks just helping to begin to help individuals make some changes that might help them, kind of like a gentle nutrition approach that might help them just feel more confident about their eating choices and pay attention to how it feels in your body and how your body is responding to it, and let that also be a choice. And so it was a great learning experience. It was right in the middle of COVID. So we had some interesting stories about how we were navigating that space, but I'm excited because I felt we were able to find a program that was feasible, right? Participants felt like they were interested in the program. They were, it kind of met their needs, and they provided great feedback. We did exit interviews so that we could continue to strengthen their eating behaviors. We saw that they were, preliminarily, they were able to reduce their binge eating episodes. We followed up with participants in the program at 4 months and at 6 months. And so they were able to continue to reduce their binge eating. And so it just gave us some hope for, what we can do in the future to continue to help them.
Wow.
It's amazing. Oh my goodness, I'm so excited.
Yeah, we had a good time. I love doing it, because it's just the people you get to meet, and it means something. As a clinician, that's really my heart. So to be able to, help people who you see in your community all the time, to be able to kind of make their lives just a little bit better, it means something.
Great.
Powerful.
Mhm.
That's when we translate research into action, that's really powerful. And that's how lives are changed and people can embrace their full health, whatever that means for them. And I think that was so beautifully said. I'm going to ask both of you to respond to a series of questions. You don't have to answer every one, though I love already the back and forth that you've established. So you may have different ideas and perspectives. And you've kind of touched on some of these questions, but let's pull out this a little bit more. What are some of the challenges that families in the United States face when seeking treatment? And this would be especially important for diverse families and families with special needs.
Absolutely. Well, I think Dr. Goode kind of hinted towards this at the very beginning when she said there are sometimes individuals who suffer from eating disorders and they may not even be aware of it, right? And so much of it is the awareness. But what we find is with eating disorders in particular, of course, with all psychiatric conditions, but with eating disorders in particular, there is such shame and stigma that is experienced when one is dealing with an eating disorder, sometimes even a lack of understanding. And some of that comes from, again, stereotypes associated with eating disorders. For instance, I have worked with Black youth, Black girls, and a Black boy, actually. Actually, that's probably even a better example. There's a Black boy I worked with, I'll never forget this. He was struggling with anorexia nervosa, restricting type. And he lived in such shame around it because he was like, this is something Black boys do not get or experience. This is a white girl disease, right? So you can imagine that because of the shame and the stigma, and he lost weight, and looking at a society, right, that promotes thinness or athleticism, especially in boys. For someone who's on a football team, all of a sudden he's losing weight. That was reinforced. Parents are reinforcing it. And he's still suffering in shame and in shame and in shame until one day things really start to go downhill and he's experiencing depression and physical symptoms and things, suicidal ideation. Well, part of the challenge in that is one, recognizing what the problem is, two, where to even go for help, right? So as Dr. Goode mentioned, usually if you're coming from a Black family or a Latino family or any other indigenous population, you're going to go to your primary care doctor. Well, if that primary care doctor or the psychiatrist, I'll put myself in there too, or a psychiatrist or any other clinician, does not have the training in eating disorders to identify, maybe because they never experienced it or they never learned about it, or maybe they carry their own explicit and implicit biases about eating disorders in people of color, then they may overlook it. Then what happens? You end up doing a $1 million GI workup that comes up negative, only to find out that lo and behold, this individual has been suffering from an eating disorder for years. So what happens then, now we are at a point where this eating disorder has not been treated and the prognosis is worse. We all know I'm a child psychiatrist at heart, so early intervention is key. If we had intervened sooner, we can get resources sooner and then really help this person to overcome their eating disorder. But instead, what happens with especially people of color, LGBTQ communities, is that they access treatment so much later in the game that it's harder to treat. Now we're talking higher levels of care. And if they don't have an eating disorder that typically is recognized by an insurance company as, being weight, having weight criteria or medical criteria, guess what? They may be admitted for a day or two and then they're discharged prematurely. And then who are they discharged to? Who are the providers taking care of them? Are they culturally aware to provide them with ethical, culturally competent treatment, right? With interventions where they're meeting that community where they're at. So the list goes on. Do they have the financial resources? Do they have the support in their families, right? Who look at them on Thanksgiving Day and say, oh, you look so good. You've been losing weight, baby. Good job, right? And this person is now even ashamed to tell their grandma they're suffering from an eating disorder. So there's so many things wrapped up. I know that was a long answer to your question, Liz, but it just highlights how much work we have to do within this field, because there are so many dynamics at play here, and there's so many barriers to getting that access to care. Another thing, one last thing I'll add, we talk about providers who are trained. Well, when we think about providers of color even, we look at all the psychologists in the United States, only 4% of them identify as Black. We look at all the dietitians who identify as Black, that's 2%. Psychiatrists, less than 2%. So that means, yes, we need to do work to improve the amount of individuals of color who are, to increase those numbers in general, to make sure that they're actually seeing individuals with eating disorders. But we got to get to work for the folks who are in the field. So all of you who are on the ground doing this work, who've been doing it for years, how can we make sure we have more awareness, sensitivity, training to make sure that we are addressing all these barriers? So I know that was a long answer.
That was great. And I feel like
so good. Dr. Dzirasa, you hit it like right on the head. Just I really don't think I have anything additional to add. I felt like you covered, the main things that are really challenges. And so our work is like, what are we going to do about it? What's our next plays? How are we going to help, improve health equity in this way? So
yes, and funding the research is key though, because Dr. Goode, what you just shared about this intervention is huge. To see that people are coming in for weight loss and you're meeting them where they're at, but also kind of directing things in such a way that we can get away from the numbers and really help people with, okay, how do we have a better relationship with food, right? That's so key in our community. So I'm so excited that you're doing this work. It's so powerful. And it really goes into, okay, we need to get more people into research. When we're looking at the research, going way back, into time, it's like we have been researching one or two specific diagnoses, right? And we have very limited representation in those research studies. So that's why I'm so excited we're talking about this, because we have to get folks into research. That's where it starts.
Look, I see the pipeline. You think about, I know for me, when I learned about research, I was already practicing as a clinician, and I didn't really see myself. When I learned about research, I didn't really see myself there. And so it was hard for me to really grasp it. And so you think about how can we reach as far back in the pipeline and catch people early? Because really, if you're going to have a career in research, you need to start early. There's so many things, that you have to get ready for. And how, I think that's one thing that's going to help is, and I see it now, people who, reach out and they're like, I'm interested, I'm a junior, I'm in high school, I'm first year in college, I'm interested in eating disorders, and I really try not to turn anybody away, and just to at least meet with them and to talk to them about, kind of some of their interests and give them the tools, right, to get on the path and help them find mentors to really, because that's going to be really our next challenge, is how we can diversify the field. I feel like we have certain tracks that are pipeline into eating disorder work. And so if you don't get in certain track, you're not going to really feel confident and have the training. And so, like, I think I'm in a school of social work, and our students, it's only a 2-year program. So students don't have a lot of time in the coursework to really get what they need. So they're going to have to either get it in their field placement or after they graduate. But to begin to put it in their mind now, to get that training so that they are able to feel like they have some competency. I think people sometimes feel like, I can't do it, I'm not trained to do eating disorders, but what can we do to help people feel better about that, right? Because we know people need treatment and they need it from every person, everybody who's injured. We need all of you all out here on the front lines to really begin to help. So it's critical. We have to find a way to do better at that.
Thank you. So I think a couple of points to kind of pull out and then tee up the next question. Oftentimes our systems aren't set up where we think of research as belonging only to those in the ivory tower. And we forget that research has to be connected to people like primary care providers who are on the front lines providing care. And that research isn't just an academic paper. We're doing research on interventions that can actually change lives and change the health for real people, not laboratory subjects.
Right.
And to that end, you both spoke about this kind of in your introductory comments, but I would really love for you to tee up and tease out a little bit more what you learned in your research findings. And if you could summarize that and say to a primary care provider or a community psychologist, here are 3 things from this project that I really would love for you to take forward, or if you need to still make that bridge, here are things we're teeing up to take into that bridge.
Yeah.
Would you like to start, Dr. Goode?
Sure. When I think about what we've learned, I think one thing I've seen over in psychoeducation is critical. And so individuals, I think we have to think they're not going to come in and say, most people probably aren't going to come in to primary care and say, I have an eating disorder. So what they might come in and say, you might notice they've gained a lot of weight, especially with binge eating. They've gained a lot of weight rapidly, right? That's something that we see that might be a risk factor, or individuals, especially in the year before they might get treatment for binge eating, they might have had rapid weight gain. So they might come in talking about weight loss. It's probably going to be, especially if you're talking about, when I think about people in my research, everybody was coming to talk about weight loss. And so that, I think doctors felt comfortable on the weight loss track. And so they're like, okay, I can help with that. But to maybe stop and slow it down a little bit and ask a couple follow-up questions. I think about, there's certain screeners for binge eating that can be a quick, sometimes 7 questions that you can start to ask if individuals have experienced loss of control eating, and I think I found in my studies to have to break that down. Do you feel like you want to, even though you want to stop eating, you can't, like a snowball rolling down the street, do you feel like you get overwhelmed in regards and you can't stop even though you want to? And also, I think what I saw from my study is that people want the help. They just need different ways. And so we did our study in person, and I don't think I'll ever do another study in person because one, our culture has shifted. And so finding ways, I think, to increase accessibility. Right now, my team and I are working on digital health platforms to provide treatment. How can we get what people need digitally, because we know people are connected. Even the most marginalized populations, they find a way to connect. It's a survival. To survive, we have to be connected digitally. And so I think what I've seen is that while I was grateful, participants, we had them come in for about, in person, 16 sessions. They had to come in person. And so when I look at our data, on average, participants attended about 60% of those sessions. And so they came, and they were in person, but I think I'm still thinking about those other sessions. And maybe if we had a hybrid model, or been able to kind of be a little bit more flexible on how people participated, maybe we would have been able to reach them a little bit more. We didn't see like a dose effect. So those who came to more sessions, did they do better? We looked and we didn't see that in the data, because, but to think about how can we do it in 2 sessions? How can we make it a shorter period of time? How can we, be able to offer our digital program? So maybe they can, connect digitally, and then they can meet with a counselor, 1 to 2 times. How can we package it in a way? Because I found people, they weren't always interested in the long haul. I wanted to be able to have time, and, and we wanted to be able to kind of dig deep. But honestly, I think people weren't always wanting to, because they really maybe didn't have permission to really spend the time that might be needed to really, dig through disordered eating. It's complex, right? It's layered.
Mm-hmm.
And so how can we know that people might come back at different periods, right? They might come back, you might get them for a little bit now, then they're going to go away, and then they might come back a little more. And so how we can think about treatment in that way, recognizing that someone may not commit fully for the whole thing, but how can we continue to help improve their eating? And I know it depends on the nature of the disordered eating, but especially for the binge eating episodes or individuals, I've really found that individuals, they got it. Like they could cognitively connect. And so to be able to give them some things that they could be doing in their own time, ways to support each other, is helpful.
One of the things you mentioned, Dr. Goode, with regards to the participation, you mentioned that this was all done in the midst of the pandemic, and I just can't help but think, as a woman working and trying to survive in the midst of a pandemic, what other barriers?
And homeschooling.
Yes. Dual jobs, right? Of homeschooling and working from home, and the financial layers and the transportation and childcare, because the kids are home. So who's taking care of the kids? I just can imagine there being so many other logistical barriers too that may impact participation. So I love that you all are investigating that and trying to understand that, because I think that that's something that will also help to enrich the work we are doing too. Like, okay, what exactly are those barriers that, yes, we could talk about systemic barriers like oppression and racism and, challenges with, not having appropriate accommodations for individuals with disabilities and things like that in healthcare. But then there are going to be some personal barriers, right? And we talk about stigma and shame, but just the logistics of childcare and financial and doing all this in the midst of a pandemic that we are still facing day to day. So just think that that's so powerful. There's so much to learn there.
Would you both drill down a little bit more into these barriers? You've kind of given some banners, I guess I would call them, and they're things that we're reading about in the popular press, in our social science journals. But can you drill down into that a little bit more?
Yeah, well, when I first think about barriers, I think, I like to think from like the bigger going down to smaller on my brain. Yeah. So when I say systemic, though, there's so many different types of barriers that can fall under systemic barriers. So we're looking at institutionalized things that have been set up, like institutionalized racism and the impact of that on wealth and poverty in certain populations, and home ownership, right? Thinking about those social determinants of health, if you will, that are impacted by institutional things and systemic, policies that are in place as a country, within our country, so how that impacts access to healthcare, right? And funding, for healthcare, education, access to providers, we're living in certain rural communities because of issues with housing, being left out of that sector of our society, right? So there are those systemic kind of institutionalized barriers. And then I think about the healthcare barriers, right? So when we think about over 28 million people not having insurance, and individuals who are dependent on government funded insurance, and the limitations associated with treatment, particularly for eating disorders when it comes to government funded insurance. Then thinking about access to providers, if you're living in a community where you have access to a pediatrician and an internal medicine doctor who also has knowledge and education and experience working with individuals with eating disorders. So we think about that. And then you may have heard me mention some words like explicit and implicit bias, right? So for those providers who are taking care of patients, what are the things that we hold in our day-to-day that we project onto our patients that we may not or clients that we may not even be aware of? So for instance, way back in 2006, there was a study looking at clinicians who are reading the same script about an individual named Mary. Okay, so Mary could take on different types of races. She could be African-American one day, she could be Latina one day, she could be Caucasian one day. And they look to see, okay, if you are a clinician and Mary is presenting with the same exact eating disorder symptoms, based on race though, what are we noticing? And what we notice is that clinicians were much more likely to diagnose eating disorders in a Caucasian Mary than a Black Mary. So much so as 44% of clinicians caught the eating disorder for a Caucasian Mary versus 17%, 17% for a Black Mary, right? So that just goes to show we all carry our own bias. And part of the work I hope we can all do is taking ownership and responsibility to learn about what those biases may be, and to learn about populations we typically don't see every day, right? Populations that we may not, if we're specializing with anorexia nervosa, let's learn a little bit about ARFID. Let's be prepared to deal with someone with ARFID. If we're a treatment center that specifically works with individuals with ANRT, how can we make sure that we have beds that are, large enough, scales that are large enough to also take care of our individuals with bulimia nervosa or binge eating disorder, right? So we have to really, so those are some of the barriers. And then we can get down to the financial barriers, right? In terms of the fact that most doctors and the clinicians in the field don't take insurance. The fact that there are large co-pays and co-insurance amounts that people have to pay out of pocket. How are they paying for transportation? A lot of the treatment centers, people have to fly way across the country. How are they doing that? How are they getting on a plane when they're medically ill? Who's going to cover that cost of getting on a plane? When they have to go to PHP and the parents have to quit work to be with their kid for 12 weeks as their kid is in PHP, where are they going to live? How is that person going to support themselves when they're out of work because they're trying to be a good parent, take care of their kid? So those are other types of the financial barriers. And then we have cultural barriers. We have individual barriers. We could go on and on. But I do suspect that we hypothesize that, as I said, we're still collecting data. We're actually the survey is still open. So if you know of individuals who would love to participate, please send them our way. We need more participation. But we suspect and hypothesize that there are going to be certain individuals coming from larger bodies or different body types, coming from non-binary identities, coming from BIPOC identities that will likely experience those barriers in different ways. And maybe even have more barriers than others, additive effects of those barriers. So that's what we hypothesize, but we're still waiting and seeing.
Thank you. Dr. Goode, in your work, what did you see on some of those barriers with Black women with binge eating? I mean, so then that kind of gets us even more focused. But even so, I'm guessing individuals experience things differently. So their experience with barriers might be different.
Exactly. Yeah, it might be. One thing I thought that I think we might need to think about is how do we assess for disorder eating. And I think we do it in a way that's very color blind, culture blind, just like we've been trained to not ask, but there's certain questions that I think if we're going to catch the manifestation of disorder eating, the factors that are affecting it, to even have people be triggered to talk about it, we're going to have to ask different questions. So when I think about what I learned is that for Black women, we need to talk more about the experiences with racism, right? The experiences with acculturation, experiences with, discrimination and trauma, and also be able to ask about food security, and are you able to access your meal regularly, and really asking out, but we're not trained like that, right? So there's certain questions that we have determined that these are the questions that we ask. And that was likely developed without reference, right, to the culture of the individual, the ethnicity, the gender, of the individual that was in front of us. And so I think that's one thing that's going to be really helpful, is if we begin to kind of recognize and take into account who is in front of us and how we might need to ask different questions to really begin to detect the disorder eating behavior. Because individuals, if you don't ask certain questions, people may not share, and you'd be like, oh, they don't have it, because you use the language that you know to use, but they don't talk in that language. That's not their language, right? And so, though it's work, right? It's going to be work on our part, but I think that's really going to begin to enrich our ability to capture more individuals and to, be able to create packages. One thing I found that might be more helpful, I found many of my participants, they'd be like, okay, Dr. Good, I don't have time to be doing all of this stuff. What can you give me? What can you give me right now that I can use? And so I found myself giving out self-help resources. And so there's, again, when you're talking about binge eating, self-help resources can be really helpful as a first line of defense. We have the literature that shows that it can be almost just as helpful as a meeting with a counselor, depending on the nature of the eating. And so we have to recognize we're not going to get everybody in our offices. We're not. But can we get something to them, right? Something that they can easily access, easily, and even the primary care physicians, I may not know what to do, but I can give you a book, or I can refer you to this book, and just to be able to have a tool that people can get into their hands, have several titles that you can easily help people to get that information. Because people read all the time, if we're curating, the online things that people are getting, how can we create something where people can get, you think about treatment at all levels, right? And so there are going to be those who are going to come with us at the highest level, the most engaged, but there are going to be a whole lot of other people who aren't. And we got to get them too, because I think we have an opportunity to really help. And so to think about, I think as we're moving forward, what does it look like at all levels? And some of those lower levels, let's talk about that. Like, what's the lowest level someone can get engaged in treatment for disorder eating, and how we can help them?
So I love that. You have just done a masterful job all day of bridging us into the next question, which is, what would you like to see us do in order to eliminate those barriers or begin to change the outcome? And so what I heard you just say is to really meet people where they are, and for binge eating to understand people are already seeking information and knowledge. So for one thing, we have to ask better questions up front, but then we need to take responsibility to curate content that's appropriate to move them along in their journey. And probably we should do that as a field as opposed to Dr. Google, and really think about that. And I would love to invite both of you to participate and help us do better job of that at NEDA. We are just kicking off something called the Grace Holland Cozine Research Library and Resource Library. We have a lot of content already at NEDA, but what we're going to work to do is to create specialized libraries for people depending on where they are in their journey. So you will be hearing, both of you will be hearing from me, because we'll need more help on that. Resources that you like to use, that work, and we'll kind of go from there. But what else? So you're talking about educating physicians about questions to ask. You're talking about curating content to give to people. What other changes can we do to help eliminate barriers?
I think also just trying to seek additional training to understand. I mean, we've talked a little bit about racism and, institutionalized racism, systemic racism, and seeing how that might impact individuals in their day-to-day life. And even with regards to their eating disorders, with regards to trauma, with regards to food insecurity, that's already been mentioned. I think, there's just so many rich resources out there to learn more about the experiences of some of the individuals that we are serving, right? If we can have that background, then we can come in with, cultural curiosity, if you will, and sensitivity to whatever it is that they may be experiencing, and be able to ask difficult questions, right? And I think Dr. Good made a great point. I mean, we all learn as clinicians, right, that if you don't ask a teenager about their substance use behaviors and patterns, they are not going to volunteer that information to you. They are just not going to volunteer it, right? So we have to be very strategic and intentional about training ourselves and having a good understanding. That way we even know what questions to ask, right? So that we can understand. And how do we ask about eating disorder behaviors? How do we ask about trauma and that relationship to their eating disorder, and to maybe the cultural lens that comes in terms of how their family views food and body image and body shape and all of those things, and how how racism influences how we see our bodies and self-worth, right? And I mean, the list goes on, but I think if we can start with educating ourselves and just being more aware too of our own privilege, I think for some of us is like we all are coming from a place of privilege, and understanding how that might impact the patients that we serve, whether it's said or unsaid. And oftentimes it's unsaid, right? So I think that internal work, if you will, can be really, really helpful. And then, of course, the research, we talked about that. How can we get more funding for research in marginalized, especially in marginalized communities? I think that has to be a priority. I hope it's a priority. It sounds like it's a priority for NEDA in 2022. So definitely increasing the funding for folks like Dr. Good and other researchers, Project Heals. There are other organizations or other physicians and clinicians who are interested in this kind of work. So how can we make sure we're increasing the funding and participation? And I think that's the other thing, is how do we get the word out there to individuals who are suffering in silence, to help them say, hey, we see you. We see you. And I think we have that responsibility at NEDA, Project Heal, UNC, Duke, all the other institutions, all the other unnamed places that serve individuals with eating disorders. We owe it to our patients for them to understand that we actually see them. And even if they don't see it, even if they don't see how they can get access to these resources, that we still hold hope for them, and that we are committed to doing whatever it is in our power to make sure that they get access to appropriate, culturally competent, ethical care for their eating disorders.
That is beautiful.
I love that.
That is
Love it.
awesome. So one last question for you both, and I think that framed this beautifully. For all of those people who are listening to this episode, you've teed up a couple of things for them. They can fund research, they can read more, they can get involved. But what are 3 things that you would say to the people who are watching this episode? What can they do as active advocates and maybe activists themselves to really change and break down the barriers in our eating disorders community so that everyone truly can access quality care?
I think one thing that might be helpful is one of my students did a blog on our lab webpage where she talked about the question of, am I sick enough? And she found for her own personal journey, it was so challenging for her to get the help she needed, because she never felt like she deserved it, that she was, like she had enough symptoms, or is this enough? I don't know. Should I really talk to someone like this? And I find again, at the earlier stages, that's where people are at, just wondering like, is this really, I don't know, I don't want to waste their time, to get people as they're going through that cycle in their heads, right? How can we change that? Or people are, you're worth it, it's enough. It's enough. The answer is yes, it is enough, to go and begin to find out more how you could access care, right? How you can learn more to find out, to get the help you need. And I think sometimes people don't come forward is because they don't feel like, I don't know, like, is it going to be worth anyone's time? And I know, of course, we're going to have to triage individuals, right? But how can we create campaigns where people can realize, yes, at all places, yes, you don't have to suffer with this. We can help you at all stages. Yes, come see, go here. Where can you go, right? I think that's the question. What do you do? Answer that question. Help people answer that first question. What's the first stop? So that they can begin to get started.
Absolutely. I love that. And I would say I'm like, you said 3 things and I have a flood of things. So I'm gonna try to limit this to 3. So 1, I would say stories break stigma. And when we are able to share openly and freely how we suffer from eating disorders, how sometimes we don't feel the treatments that are in place address our eating disorders in a safe way, to be able to share that openly, to have a safe space, I guess what I'm saying, to communicate about your story and how maybe things haven't worked or things have been hurtful, and how we as the eating disorder community can do better to treat your symptoms, and to hear you, and to make sure that we are engaging in your treatment and your healing in a collaborative way that respects your culture and your identity and your dignity, creating a safe space for that. 2, I would say, for those of you who are watching who are in leadership, creating space for those to sit at the table. For those of us who are in this work, very few, but there are folks, dietitians, clinicians, doctors, people who represent BIPOC communities, people who represent LGBTQI communities, people who represent those with disabilities, who it would be valuable to hear their voice so that they can have a seat at the table and hopefully help to influence change in the right direction and move this eating disorder field forward, making sure that we don't forget those who are often silenced. Lastly, I would say, and this is for all of us, make sure that we are getting active in calling our local, state, federal representatives, making sure that we are making a phone calls to advocate, to put pressure on insurance companies to make sure that there is equity when it comes to treating individuals with eating disorders, that we put funding to that. And for those of you who have the resources, mental health disorders already don't get half the funding that, when you think about breast cancer, for instance, and all these other like really huge, big movements for other medical conditions, psychiatric conditions we know are at the bottom of the pot. Then when we look at eating disorders, like the bottom of the pot. So we have to put our money there. We have to advocate with our voice, but also with our resources, our financial resources. So I would encourage you, if you don't have the resources, you can participate in a fundraiser. You can do a walk. You can do anything, creative to help to raise money for organizations like NEDA or Project Heal that are funding these research endeavors and are really committed to improving equitable access to care for those suffering from eating disorders, so that we can provide hope. That's at the end of the day, that's really what we want to do, right?
That's it. Hope. We can give people hope.
That's right. I loved how both of you framed that, because you started where people are. So whether you are personally in a journey and you're looking for hope, you're looking for how can I start? The place that you have to start is to really believe you're worth it.
Mhm.
You are important, you are valuable, and it's important to reach out and ask for help. That's the first step. And then to continue to build communities that are diverse, that are dynamic, that can surround those people as they step forward to say, I need help, and please help move me along that journey. And then for all of us to remember every single day, whatever our strength is, whatever our resources, because that's not always tied to financial worth. We have voices, we have ideas, and we have strength. And we
Mhm.
need those people to come in and lift up our work in the eating disorders community at each and every step along the way. And that's why we have community, which is so important.
Yeah.
With that, I don't have any questions left. Is there anything that either one of you would like to say, either about your project or your work, or the hope that you have for this field as we kind of go into a new chapter?
I'm just excited. Thank you again for the opportunity and for giving us a voice, for allowing us to talk about the things that we're mostly passionate about. And, at the end of the day, like you said, this is a community and we all have the same goal, right? Is that all individuals who are experiencing an eating disorder can receive the treatment, that they need so that they can overcome it, so they can heal from it, grow from it, and continue to live their best and fullest lives. That's really what we want at the end of the day. So I'm excited. I'm
Mhm.
hopeful. I'm hopeful about the collaborations that are occurring within this community, and for highlighting again, eating disorders, different types of eating disorders and communities that often get left out. So I think we are on to some, I love the momentum. I really do. So thank you for
Me
having
too. Yeah, me too.
Yes. Yeah, I'm
Dr.
grateful
Good.
to have a seat here at this table, and just to be able to begin and be part of the discussion as we look forward to where we're headed. I think our future is bright. I love that we see us talking more about this in our culture, right? And recognizing some of the things that have maybe brought us here to this place and really seeking to shift those. So I feel like we have an opportunity, we recognize where we've gone wrong and now we can start to build. And so that's pretty exciting. So I'm excited what's coming next.
Well, thank you both. You are agents of change, and you are giving a lot of people hope. So thank you for the work that you do every single day. Thank you for taking time out of those very busy days to share information about the research, but also more broadly to push us all as members of this community to think about barriers to care and what we all envision, which is a world where everyone who needs access to care will have access to quality care. So thank you for framing all of that. And with that, wishing you a happy Thanksgiving.
Thank
And we
you.
look forward to continuing our wonderful collaborations.
Thank you.
Bye.